You know, in the world of neurocritical care, everything can come down to a single number. And we're talking about a number that can mean the difference between a full recovery, a lifelong disability, or even worse. That number is the oxygen level inside the human brain. Today, we're going to explore why getting that number right is so incredibly important. It really all comes down to this question. It's what doctors in operating rooms and ICUs are grappling with every single day. See, the brain is an amazing organ, but it's also incredibly fragile, especially when it's being starved of the one thing it needs most, oxygen. And the risks here are huge. Just look at major cardiac surgery. Neurologic injury isn't rare. It's actually a common complication. In fact, up to half of all patients can have some kind of cognitive decline afterward. And the stroke rate? It's between 1% and 3%. But get this, if a patient does have a stroke after cardiac surgery, their risk of death shoots up by a staggering 10 times. The stakes just could not be higher. So here's our game plan for this explainer. We're going to start by looking at the moments when the brain is most at risk. Then we'll check out the tech we use to get a window inside. After that, we'll uncover a major dilemma with these devices, see how researchers are using big data to hunt for the right numbers, and finally, wrap up with what this all means for patients. All right, first up, let's understand exactly when and why the brain gets into the danger zone. There are two really critical scenarios where this risk just skyrockets. First, during complex operations like cardiac surgery, where blood flow and pressure can swing wildly. And second, after a traumatic brain injury, a TBI, where swelling and damage can literally choke off the brain's vital oxygen supply. And the consequence of that oxygen getting cut off, a condition known as hypoxia, is severe. It's the silent enemy behind so many of those devastating outcomes we just talked about: memory loss, trouble thinking, stroke, and in the absolute worst cases, death. This is the problem we're trying to solve. So, how do you fight an invisible enemy like that? Well, you have to develop technology to make it visible. And that brings us to our next section, how we create a window on oxygen. One of the most common ways to do this is called cerebral oximetry. It uses a tech called near-infrared spectroscopy, or NIRS for short. The easiest way to picture it, think about that little clip they put on your finger at the doctor's office to check your oxygen. This is basically the same idea, but for your brain. They stick sensors on the forehead, and it gives a non-invasive snapshot of the oxygen levels in that region. But what if you need a more direct, up-close look? Well, for that, there's another method, brain tissue oxygen monitoring, or PBTO2. Now, this one is invasive. A tiny probe is surgically placed directly into the brain tissue itself. The payoff is that it gives doctors a continuous, minute-by-minute, and incredibly precise measurement of the actual oxygen pressure right where it counts. So we're left with two really different ways to tackle the same problem. You've got NIRS, which is easy and non-invasive, giving you a bigger picture from the outside. And then you have PBO2, which is invasive, but gives you the super direct, continuous data stream from the inside. Both are crucial tools, but this is where things get really complicated. And that complication brings us to what we're calling the device dilemma. Because what in the world do you do when the tools you rely on don't actually agree with each other? To figure this out, some researchers designed a really clever study. They took two of the most popular NIRS monitors out there, the InVos and the Equinox, and they placed sensors from both devices on the exact same patients during cardiac surgery. The goal was simple. If a patient's brain oxygen drops, both machines should catch it, right? Well, the results were frankly alarming. Over the course of the study, the InVos device flagged 20 different times where a patient's brain oxygen dropped significantly. But the Equinox device, monitoring the same patients at the same time, only detected 3. That is a massive difference. So what on earth does this mean? The huge takeaway, as the researchers put it, is that these devices are not interchangeable. You can't just pick one safe number for brain oxygen and apply it no matter what monitor you're using. Each machine kind of speaks its own language. A reading of 20 on one device might not mean the same thing as a 20 on another. Now, this device dilemma points to a huge problem, but it also points us toward a solution. If every device needs its own unique targets, how do we find them? Well, as we're about to see, the answer lies in big data. In a completely separate, landmarked study on traumatic brain injury patients, researchers didn't just look at a few dozen measurements. They analyzed over 1.3 million minute-by-minute brain oxygen readings from 190 different patients. This absolutely massive dataset let them hunt for patterns connecting oxygen level to patient outcomes with incredible detail. And this right here is their most critical finding. Look at the chart on the left. It shows the average brain oxygen level for patients. See how all the lines are kind of jumbled together? The average doesn't do a great job of separating patients who had good outcomes from those who had bad ones. But now, look at the chart on the right. This one shows the amount of time each patient spent below a specific oxygen level. And here, boom, the lines split dramatically. You can clearly see that the patients who ultimately died spent way more time below that critical line. So the big takeaway here is this. A patient's average brain oxygen level can be dangerously misleading. Someone can have a perfectly fine average, but if they had a few short, severe dips into that danger zone, those are the moments that could cause the real damage. It's not about the average, it's all about avoiding those dips. By digging through all that data, the analysis found a critical line in the sand, 19 millimeters of mercury. This was the number that most reliably separated the good outcomes from the bad. This is the danger zone. The main goal becomes doing everything you can to keep a patient's brain oxygen above this line. But that's not all the data showed. While staying above 19 is the absolute minimum, it seems there's an extra benefit to keeping levels even higher, aiming for a target of at least 33. So this gives us something really powerful, not just a single danger number, but a whole treatment window. Stay above 19, but really aim for 33. So let's put this all together. What are the key takeaways from all this? Let's break down what this really means for patients and the doctors on the front lines. Okay, first and foremost, different monitors give you different numbers. They are not interchangeable. Second, and this is a big one, what really matters isn't the average oxygen level, but the duration of time spent in that danger zone. Third, this gives us that powerful idea of a treatment window with a clear goal for TBI patients. Stay above 19, but aim for 33. And finally, all of this just screams that we need more research to create specific, customized guidelines for each unique device. And that leaves us with one last, really fascinating question to think about. We're diving headfirst into an age of incredible medical data, with monitors that can track hundreds of things every single second. But as all of this research shows, just having more data isn't always better. The real challenge moving forward is figuring out which of the millions of numbers we can now collect are the ones that truly, truly matter.